What is the typical route for a head and neck cancer patient? Does it start with surgery?
Well, it really depends. And what I say is that head and neck cancer, for the most part, is a locally advanced disease. And I say that because it has certain implications about the way we think about treating patients. And what I mean by that is that the great majority of patients with head and neck cancer will initially present with either a localized tumor or a tumor with involved lymph nodes. In other words, and that's 90%, 90% of patients will present that way. In other words, it's actually uncommon for patients with head and neck cancer to present with metastatic disease. That's different than many other cancers, lung cancer, pancreatic cancer, breast cancer. Many times in those situations, patients, when they come to the attention of a physician, unfortunately already have metastatic disease. That's not the case with head and neck. And so what does that mean to have a disease that is locally advanced? Well, the most important thing, the first thing, is that most patients we are going to be treating with curative intent. That is, we're going to try to cure the disease. The second thing is that the disease is going, and its treatment are going to have functional outcomes potentially for that patient. And that gets back to something I was saying before in terms of think about how much of how we define being human happens above the clavicles. I mean, it's really what makes us human. And so that has dramatic implications, obviously, for the patient. So for head and neck cancer, the fact that it's a locally advanced disease means that we're going to think about curing the majority of patients, at least try to, but we're also going to think very strongly about how can we preserve those critical organs of swallowing and speaking and socializing. It also is a disease that tends to recur or come back in a locally advanced fashion. And that's the other part of why I call it a locally advanced disease. So unfortunately, oftentimes when head and neck cancer recurs, and obviously we try to avoid that, it comes back in the same area. And of course, that has the same implications for what we try to do with treating patients.
So even using radiation and chemotherapy, other immunotherapies, the cancer will still come back.
Yeah, and I realized I didn't really answer your question in terms of the approach to the patient. I just gave you some general guidelines. So let me step back and talk a little bit about that, and then we can talk about the integration of different modalities.
Sure.
The approach really, it depends on a few things. The primary is really where the tumor is, where the primary tumor is. And the reason behind that is what I was saying about functional outcome. For instance, if somebody has a small tumor of their tongue, of the front of their tongue, let's say, a surgeon can easily remove that, and the patient can continue to speak and swallow normally. And so in cases like that, obviously we would do surgery first, and then if the patient needed it for whatever reason, we might follow that up with radiation or chemotherapy. The converse is true for a tumor that may be farther back in the throat. So let's say an area called the oropharynx that involves the throat that you can see, the part of the throat that you can see when you open your mouth widely. Well, if we take out a tumor there, that will have much more significant implications for long-term function. The patient may not be able to swallow or speak normally again. And so for those types of tumors, we would take a non-surgical approach. Not that surgery couldn't be done, it could, but sometimes it's better not to do surgery upfront to preserve function. So again, it's those two goals that we have to keep in mind. We want to cure the cancer, but we want to preserve function. Then you mentioned about chemotherapy, radiation, immunotherapy, and in a non-surgical approach, that's what we would do first. We would do either radiation therapy alone or radiation and chemotherapy, and that primarily depends on how extensive the cancer is. the more advanced it is, the more likely we are to add chemotherapy, because we know from clinical trials, getting back to the importance of clinical trials, we know from clinical trials that adding chemotherapy in advanced cancers does improve survival. And so that's predicated on really how where the cancer is and how large it is.
Mm-hmm. What about treating more advanced disease? Are the choices different?
Sure. Well, let's define, what we mean by more advanced disease.
Advanced.
If the cancer is still localized, so even if it's an advanced, let's say it's a large tumor that's invading other structures. Let's say there's a lot of lymph nodes involved. We would still take, assuming the patient, ultimately it's always the patient's decision, but we would recommend to the patient often that we try to take a curative approach. And that curative approach in quite locally advanced cancers would almost involve everybody. So chemotherapy, radiation, and surgery almost always involve those things to try to eradicate the cancer. If we're talking about an advanced cancer in the sense that the cancer had come back, so it's recurrent, or it had metastasized, then we really are talking mostly about systemic therapy or some sort of drug therapy. And now that almost for all patients includes immunotherapy, again, based on the results of clinical trials. And that's relatively new. That's been approved now for about 5 years, maybe 6. But it has led to dramatic improvements in outcome for these patients. Now, when we look at the long-term data from these clinical trials, we're beginning to see that about 1 in 5 patients with recurrent or metastatic disease are still alive 5, 6, even 7 years later. That's something that we did not see in the past. So immunotherapy has been a tremendous advance forward. Now, of course, the other side of that is 4 out of 5 patients are still dying. So we clearly need to do better. But the fact that 1 out of 5 is surviving is amazing.